Okay, awesome.
There we go.
And so we're going to talk today about another way to add to your toolbox, which is the idea of utilizing laser therapeutics kind of as an adjuvant therapy in the treatment of PHACE syndrome. And I just want to give a shout out to all the amazing families with PHACE syndrome. I've been so joyful and so lucky to learn from, including some who are already on the meeting, and I'm going to share their stories today, and lots of gratitude to them just for sharing their wonderful kids and giving permission to talk about some stories. And I'll say I'm a dermatologist at the University of Wisconsin. I work with Beth Drolet, who I know you heard from this morning, and it just has been so remarkable to learn from these patients, but also work at an institution that really has been on the cutting edge of PHACE syndrome research. And I think our ability, to learn from our patients, but also develop cutting edge protocols like the kind of imaging protocol, which Beth probably talked to you about this morning, has been just a really exciting and joyful time for me. So thank you guys so much for having me. All right, so we're going to get started. And here are some objectives today. We're going to talk a little bit about how you choose laser parameters, the laser device itself, and really why laser works at all for PHACE syndrome and infantile hemangiomas. We're going to show some before and after pictures and really talk about reasonable expectations for what laser can add, and also dive a little bit into timing of treatment, because I think in infantile hemangiomas, that's quite different in some other vascular entities, including capillary malformations or port wine birthmarks. And then we're going to talk a little bit about when you do it, how should we do it? Is it in office? Is it anesthesia? And there are really no perfect answers to this. There's a lot of shared decision making. So I can talk to you a little bit about kind of how I think we approach that. So Rox Anderson is one of my mentors. He is a really genius inventor. He's invented actually most of the laser technology we utilize in dermatology. He's a professor at Harvard. And this is a quote of his that I really love. It says, "Laser light has the same properties that you would wish for your own children. It's energetic, powerful, yet easy to control, easily focused, and on a well-defined wavelength that's coherent." Well, neither of our children exhibit most of these characteristics on any regular basis. They really nicely encapsulate what laser does. And this, I think, is really a remarkable area of science because it allows us to use light to perform very targeted microscopic surgery that only hits your target, which in the case of infantile hemangiomas and other vascular birthmarks is blood, while sparing that surrounding tissue. And if you hit your parameters right, you get really good execution of the target, which in this case means you actually ablate the blood vessels that remain without causing really any other damage to the surrounding skin. And that's an incredibly satisfying journey to take our patients on because it's really, really safe, and it works incredibly well. So this is a little bit of a busy diagram, basically showing why and how laser can do this. And this is based on a principle that Rox and John Parrish coined in the mid-'80s called selective photothermolysis. And that means that if you pick the right wavelength of laser, you get to execute one of three targets. And your targets here are called chromophores, and they're listed on the right. They're either hemoglobin, which is blood, melanin, which is pigment, or water, which is in the superficial layers of the skin. And so when you look at this red curve here with absorption on the left, and the wavelength on the x-axis here, you can see that the lower wavelength lasers tend to be a little bit better in terms of the absorption for blood. And that is why most of the time, particularly for infantile hemangiomas, we utilize the pulse dye laser because it's really effective at targeting hemoglobin. And then it's a relatively low penetrating laser, so it doesn't have a lot of the side effects which some of these longer penetrating laser wavelengths can have, and that includes scarring. So if we move on, and so in general, the shorter the wavelength, the less the penetration, the longer the wavelength, the deeper the penetration. So for example, if you have a deep infantile hemangioma, using laser, unless you're using a very long wavelength laser, which I would tell you has many, many increased risks, scarring being one of them, even at very low energy levels, you're not going to execute your target at all. And so when we're talking about patients with PHACE syndrome, really the use of laser is best designed to target the residual telangiectasias, or that residual red that we get even after treatment with propranolol. And propranolol far and away is our most effective first line option. The earlier you start it, the better the outcomes we know. But even still, a lot of patients wind up with kind of this very superficial, almost like kind of lacy blood vessels, or sometimes we use the word telangiectatic, and that's amazingly amenable to laser. And so I hope this slide will show you that, because the target in PHACE syndrome at the end of treatment actually is quite shallow, those blood vessels are really high up in the skin. We don't need a longer wavelength laser to hit them. And that's part of the reason why the shorter wavelength lasers, which actually pick up blood the best, even though they don't get you a lot of depth of penetration, they work very, very effectively for our patient population. And then the other thing I would add is that when the light goes through the skin, it actually has to go through the top part of the skin, which is called the epidermis. And that kind of joins the dermis where the blood vessels are at a region called the basement membrane zone. And that basement membrane zone is actually lined with our pigmentary cells, which are called melanocytes. And so the light actually has to get through that melanin in order to hit the target, which are the blood vessels, which you can see here in the dermis. And that's one reason why we'll say, laser in the summer, we want to be really, really cautious around sun protection, because the more pigment you have in your skin, the more likely you are, one, to have decreased efficacy from the laser because it's getting confused by the melanin high up. And two, when you throw energy through melanocytes, there's an increased risk of pigmentary change after the energy, and that's called post-inflammatory pigmentary change. We use epidermal cooling in all forms of laser to prevent injury of the epidermis. And this is actually the primary way we avoid melanocyte interaction, by cooling the top surface of the skin and allowing the light to penetrate deeper to get exactly where we want it to go, which are where these red blood vessels are, high up in the superficial dermis. And if you look at some of the studies where they've been able to estimate kind of what the level of penetration of the pulse dye laser is, we get about somewhere between 0.5 millimeter and 1 millimeter in depth. And that's one of the reasons why this truly is not a scarring laser, unless you're really stacking pulses and you're doing something sort of beyond the bounds. And I would say, to everyone on this call, whenever you're handing your child over to a laser surgeon, you want to know, what their experience level is, how many patients they've treated with PHACE syndrome, because of course you want to make sure you have somebody who's really expert at doing this. But in general, cooling of the epidermis is really what allows the light to hit its target without any of that epidermal damage. And these are really the three parameters that we have to get right in order to actually make it effective to ablate the vasculature and make it less red. And it's a little bit of a dance to try to hit all three of these parameters. But in general, we have some tools to think about how to do it. So the first is you choose your wavelength, which in fact is the laser you choose based on that first curve I showed you. And that's what gets you selective absorption of the target. So our target in hemangiomas is blood. You want to make sure, if you're dealing with a dermatologist, that in fact they're using a laser that's to be tropic for hemoglobin. The second, and probably the most important that I teach our trainees, is that the pulse duration, and that really is how long the energy gets delivered over, that is what really gets you heat confinement. That's what allows you to ablate the vasculature and spare the surrounding tissue. And I'm going to show you a slide in a second, but that's all based on vessel size. And then the fluence is really the exposure dose of energy. That's how much energy you're delivering in every single pulse. And so it's really the kind of artistry of thinking through all three of these parameters that if you get them right, you really get an excellent outcome. And this is just to talk a bit about pulse duration. So in fact, one of the principles of selective photothermolysis, which Rox coined many, many years ago, was that the way to confine heat to the vascular structure and spare all the tissue around it is to deliver that pulse of energy in less time than it takes the vessel to cool. So if you overheat the vessel, you get all this heat that diffuses around the tissue, and that's when you get damage. But if you deliver the pulse in less than the time it takes the vessel to cool, you actually confine the energy, you just ablate the vessel, and that means you deliver light, which turns to heat, which diffuses across the vessel wall and then gets it to go away, basically to ablate it. And it turns out that that time to cool is all about the size of the vessel. And so, when we look at a patient, we're kind of making a blind guess about it. And many of us, and I have a lovely research collaborator at UC Irvine, Dr. Kristen Kelly, who's the chair of the department out there, but we're actually using kind of novel in vivo imaging to say, okay, we're guessing about how big these vessels are. If we can quantitate them more precisely, will that allow us to create almost like a precision-based parameter for every single patient, where we say, okay, we've imaged 3 areas of your birthmark. We know exactly how the vessels are. This is how we should select the settings. But in general, what I teach our trainees is you should be thinking about how big the blood vessels are when we set the laser. I'm going to show you lots of pictures that I hope will make this a bit more clear. But capillary malformations, they have super, super teeny little vessels in little babies. You want a very short pulse duration. Small vessel, short time to cool, short pulse duration. Infantile hemangiomas, and you can see this is actually histology from them, they're quite a bit bigger. So in general, we think you need a little bit of a longer pulse duration. On the other end of the spectrum, a different kind of vascular malformation called a venous malformation, those have huge dilated vessels. And so then you're looking at, a really long pulse duration, probably the longest I use to treat any kind of vascular malformation. So now for the fun stuff, where I get to share some patient stories and show some pictures. And I hope to interweave into this kind of some of the discussion around when we treat and the timing of when to add laser. So this is one of my favorite patients. Her name is Claire. She arrived in clinic breathing through a straw because she, in fact, had an S3 infantile hemangioma. She had a sternal cleft, she had a median raphe, she had an airway infantile hemangioma. And we started propranolol right away. Everything got better. I took advantage of the fact that she got bronchoscopy, just like ENT would go down and scope to look at the airway hemangioma once or twice a year until we got her off propranolol. And at that time, it was just like, well, I'll come in for less than a minute and add laser. And she had 2 lasers. She's now 3.5, and she's actually followed by Beth. She's had nothing more. And you can see she just has a little bit of this kind of residual telangiectasia. You can actually see where I lasered previously. If you see these kind of clear circles, that's where the light ablated the previous vessels. And I think Beth's going to go back and do another one, but this will be really easy to take out the rest. Again, just focusing on sort of the in-between areas where there are residual vessels remaining. If she had not had the opportunity, because we were scoping with ENT anyway, I'm not sure I would have done any laser until a bit older. And I think one of the things I want to leave you with is, unlike in other vascular malformations, including, for example, Port Weinstein's, where we say, There's a privileged time where laser will be effective. The earlier you start, the better it is. In infantile hemangiomas, I actually don't think the timing matters at all. Whether I had not lasered her, when she was little or not, this will be easily amenable to treatment. And so one of the takeaways of this talk is, it's really a little bit of shared decision making about when you decide to do this, whether it's sometime, early, before the child is 2 or 3, or when it really bothers them a bit more, closer to kindergarten or even a bit after. This is another one of my patients who came in. She actually was referred for a port wine stain or a capillary malformation, but you can see this is an S2 facial infantile hemangioma. She got started on propranolol, very, very quickly. I did 1 or maybe 2 lasers in the office sometime between about 6 months and 14 months. And this is her now at 3.5. She just has a little bit of that really superficial telangiectatic remnant. And because it's so close to her eye, we're going to do 1 5-minute mask anesthesia. And I think we should be able to pull out probably 80 to 90% of that before she goes to kindergarten. So really nice outcome. This is one of Beth's beautiful patients, Lily, whose family is really involved in the PHACE syndrome community. She's had an amazing outcome. She was started on propranolol at the right time. And you can see Beth's done a couple of lasers, I believe all awake, and she's had really an amazing outcome in terms of the way, the residual remnant looks, but there is a little bit of maintenance treatment that happens, maybe once a year or every other year. One of the points that I wanted to make here, I think I have one other picture of one of my patients after this, is that sometimes in the residual kind of vascularity after propranolol, we'll see varying morphologies of vessel. And as I said to you before, the bigger the vessel, the longer the pulse duration. I would tell you here for Lily, she's got just a little bit of that kind of very small pinky red vasculature on the malar cheek. And then if you can appreciate kind of laterally along the cheekbone and along the mandible, these slightly larger reticular vessels. And so we think about altering the pulse duration for them because our target is you move the laser, you're going to see extravasated blood. And actually on the larger reticulated vessels, when you fire the laser, the whole vessel should disappear. So it's really satisfying when you're treating, you can actually know whether you've hit your parameter. And I often say to the residents, like, this is not a cookbook. You don't just set the laser and then run it. You're really going to have to watch the tissue carefully to make sure that your parameters are effective. Otherwise, we adjust them so that you get more bang for your buck. And here's another picture. This is Evelyn, my little patient I showed you before. This is actually an earlier treatment before I did 1 laser of her. And it's a really nice image showing you, these tiny branching telangiectasias. They're a little larger than those really small pink red vessels. And so for her, I do a slightly longer pulse duration, at least on the first pass. Sometimes I'll go back and cool and then cover that with a shorter pulse duration. But those are kind of the strategies that we use to get the most bang for our buck from the treatment. We know we have histologic markers of success. So if you, use in vivo imaging before and after, you can actually see that the vessel has been removed. And that's because, we're taking light, changing it into heat, and actually blasting through the wall of that vessel. And usually the endpoint that we're looking for is rupture, which manifests as that purple or bruising in the skin. And in general, if you don't completely coagulate the vessel, you don't absolutely ablate through the wall, you're not going to get the desired effect, meaning you may get a little bit of lightening, but you're not actually going to ablate the vasculature. And this is just a model kind of showing you what that looks like. This is a rat model with a dorsal skin window showing you that when you laser, and you can see the pulse of light here, you're actually getting, rupture of the vessel itself. And then that vessel will kind of clot off and be ablated and disappear. This is one of my very favorite patients, Addie, and I think her mom is still on. I'm not 100% sure, but I know Erin is still on. And she was kind enough to actually send me a lot of pictures of her journey. And I want to share her story a little bit because she's just such an amazing kid. So Addie, you can see like gorgeous, beautiful young woman. She's 10, and she was treated with propranolol without laser and came to me. Maybe I think we've done 2 lasers. Erin, correct me if I'm wrong, but I think it's been 2.
Yep.
And okay, great, thank you. This was before I met her. So right before I met her, you can see she's got those kind of small, bright red vessels really high up in the skin. They're not as branching and telangiectatic or reticular as you would expect. As we saw in some of the other patients where I was saying I might use a longer pulse duration. She also has some involvement of her lip, which the first time I think we decided not to treat. And then I went back and did a little bit on the second round of laser. But, she's had a great outcome, but this was bothersome. And so you can see like Addie's so amazing. This was immediately post-op. And we did this with a very short amount of general anesthesia. So mask anesthesia only, probably took me 8 to 10 minutes to do her entire area. You can see the purple circles. That's where the laser has fired and actually caused vascular ablation. So that means I've used a pulse of light, created heat that diffused across the vessel wall and theoretically then taken down the vessel because I've ablated it. And so I think this is either the first or the second, but I don't think we treated her lip here. And then you can see she sent a picture. I don't know, Erin, what was this, like 48 hours after, do you think?
I think this was the next day, actually.
The next day. Okay.
Yeah.
So you can see it gets like even a little more, exuberant. And that's because actually typically we can get a tiny little bit of vasculitis from inflammation in the skin post laser. And so I'll usually say to parents, like, she's going to look like she got in a bar fight and lost, but that's actually our target, so we can really know she's getting better. And this is after, I think, 2 lasers, and you can see here she's like the cutest thing ever, but really good response. We may do maybe one more, and including one more on our lip where I think we'll get a lot of benefit, but really significant improvement. And Erin, I don't know if you want to add anything about the experience. I'd love for you to jump in.
Sure, we can do that. Addie is absolutely embarrassed right now, so I don't think she's going to add anything, but no, you weren't. You were fine. But yeah, it was a great experience for Addie. She didn't have anything, like you said, until she was 10 years old, and she chose to do this. I think she was very active in planning this. She wanted to have anesthesia. She did not want to do it while she was awake, and Dr. Arkin was amazing. So, and yeah, I think we'll come back one more time.
Yeah, she's just like the best kid ever. I mean, we're the lucky ones. Addie, I'm sorry I embarrassed you. You are the cutest ever. Thank you for letting me share your story. And thank you, Erin, for jumping in too. So, I think the big question here is like, when do we do it? And I think there are a couple of principles. The first is propranolol first, as early as you can, because that gets you 90 to 92% of the way. And the laser is just kind of an add-on tag on. And I think, probably, 1 to 2 treatments gets you most of the way, and maybe 3 to 4 gets you all of the way in my clinical experience. And I'm not sure that the timing matters at all. When I have kids with capillary malformations come in at a month, we have a totally different conversation that says, there's an opportunity in the first year to get more than we'll ever get at any other time. And I don't feel that way at all for infantile hemangiomas. I think it almost doesn't matter when you start. And, I think Addie's a perfect example of they started when it really was something meaningful to her. And I guess, I think this is really about shared decision-making. If there are opportunities during anesthesia, if you're imaging or you're scoping or something like that, this procedure it's not agonizingly painful by any stretch. I mean, I'll tell families it feels a little bit like the snap of a rubber band. And I have many kids who do it in the office, particularly with Port Weinstein's, by 5 or 6, they're absolutely fine in the office. And we do ice and we do all kinds of incentivizing, where they're in control. We'll do 3 pulses and then ice and a break. But the one pearl is you really do not want to start this too early. And that's because when the hemangioma is still proliferating, you can get ulceration. And I do think in FACE syndrome, there's a bit of a longer proliferation time. There are also some locations you really need to be careful of, like around the lips and the ears, where there are some watershed vascular distribution areas where you can actually cause ulceration. So this really is about kind of shared decision making. But I think, if you have a physician you trust, having that conversation really involving, the parent, and if the child is older, absolutely putting the child in the driver's seat is really important. And so these are my little pearls, like make sure you have the right laser. PDL is always what I reach for because it's completely non-scarring. It's non-scarring because it only penetrates, very superficially into the dermis. And so if you have a problem that's much deeper, it's probably going to be ineffective. But for FACE syndrome and for infantile hemangiomas, when we've treated previously with propranolol, it's a really great device to reach for. Pulse duration is your most critical parameter, and it's determined by vessel size, which is still a little bit of guesswork. But at some point, I think we're going to have more in vivo imaging to help guide more precise parameters. And then make sure you're working with a laser expert, not only who knows how to treat hemangiomas, but also who knows how to treat kids. The one thing I would add to this is that for some patients who have not just telangiectasias, but a little bit of lumpy bumpy, maybe because they were started on propranolol a little bit later, there are some additional lasers that will add to that. And I usually will reach for a very low fluence ablative fractional laser, which is very good at skin remodeling. And so I think, we don't have a lot of those patients, fortunately, because they get treated, appropriately and early. But that's the one other tool I reach for if you're trying to reduce some of that lumpy bumpy. This is your endpoint, just like we showed on Addie. It looks like you've gotten a bar fight and lost. If you're lasering before there's kind of telangiectatic component or those bright red, really superficial vessels, like I'll sometimes do it in kids who have a facial hemangioma after 6 months. It seems to help them just taper off the propranolol a bit faster. Then your endpoint's a bit different. You'll see a little bit of graying, but no purpura. And then if you're going to do it in the office, it's absolutely critical to put kids in the driver's seat. So I often will, for babies, do it on a parent's lap, or older kids, parent nearby, music, ice, put the kid in the driver's seat. If they're older, they get to hold the ice. They tell you when to start and stop. We do use eye protection because obviously, the one really big risk of all lasers is that you can cause damage if it fires directly into the retina. PDL overall is a very safe laser, but we use all kinds of protective equipment to make sure that kids are safe from an ocular perspective. And then post-operatively, I've started doing a little bit of topical steroid just once, mostly for Port Weinstein's, because there's some data that shear strain can actually maybe activate the blood vessels a bit more. So one application of triamcinolone maybe reduces that inflammatory response. Most kids actually don't have any pain. There's a little bit of burning, maybe in the first, 2 to 3 minutes after. You can do all these other things like ice and elevation, Tylenol. Vaseline is a good thing to add just to protect the skin surface. And because I talked about the role of melanin, utilizing sun protection during the summer is really important. So that's what I got. And I would be so happy to answer any questions in person, and certainly take my email. I'm happy to help in any way I can offline as well.